Now I'd like to introduce our presenter today. Today I have Dr. Nigam Shah with me. Dr. Nigam Shah is a professor of medicine at Stanford University and chief data scientist for Stanford Health Care. His research is focused on bringing AI into clinical use safely, ethically, and cost-effectively. Dr. Shah is an inventor on 8 patents, has authored over 300 scientific publications, and has co-founded 3 companies. Dr. Shah was inducted into the American College of Medical Informatics in 2015 and the American Society for Clinical Investigation in 2016. He holds an MBBS from Baroda Medical College in India, a PhD from Penn State University, and completed postdoctoral training at Stanford University. So thank you for being here. I'll now pass it over to Dr. Shah.
Thank you, Jackie. It's great fun to be here and talk about this new course offering and contextualize it in light of all of the fun things happening on our campus. So let's take over slides. All right, so one of the things that we're really excited to share with you is that, yes, there's a lot of buzz about AI, there's a lot of buzz about ML and all of those things, but a little known thing that we often do not talk about is the data. Your AI, your ML is only as good as the data it is trained upon. And we like to think of data in the form of timelines. So we use data from these patient timelines to build the AI or the machine learning, or generally speaking, to build models. So to orient ourselves, we have an arrow of time going left to right. And we have there's a fictional individual who got admitted to the hospital about 4 times. In certain hospital stays, they also ended up in the ICU. And then below that are all of the different data types that we collected during their treatment. ECGs, blood pressure, respiratory rate, cardiac output, medication orders, and some documents are written, lab tests and reports are collected, and so on. And we love to start thinking about AI, responsible AI, machine learning, all of that, with this data view in mind. And let's call this thing a patient timeline object. And then the reason this matters is in a typical healthcare setting, at any given point in time, we do not collect everything. So if we look at any time point, one of those vertical columns, some modalities are collected, the ones that were necessary. Or if you look at a particular row of data modality, there is no particular individual, including the patient, that would have a longitudinal coverage for about 5 or more years. And that is crucially important to know, because how we manipulate these data, these timelines, what we do to them, how we process the text, how we do the feature engineering, all of that has a lot more effect on your final AI or model performance than anything else. And that is something we cover quite heavily in the classes that we teach here. So let's say we've got that foundation applied. We have these timelines and we have them from millions of patients. So with them, we build models. I've put models in a little box on the left because that's not what we're going to focus on today. They could be logistic regressions, they could be deep neural networks, but what we'll focus on is what do we do with those models in healthcare? And I would argue we do 2 big things. We make decisions about whether to treat a patient and how to treat a patient. So the whether to treat is in this light orange, and the how to treat is in blue. From a computational standpoint, the whether to treat can be further broken up into a task of classification or diagnosis in medical parlance, or a prediction task, a proper future-looking estimate, otherwise known as prognosis. Now, in general language, often these terms get abused a little bit, and we might say things like, or you might hear things like, oh, we analyze this image and we predict there's pneumonia, or we analyze this image and we predict there's a dog in there. It's not a prediction, that's a classification. The dog was already a dog before you took the picture. The pneumonia was already there before you took the x-ray. So that's in the top row classification. And that's also something to pay attention to, because a lot of things in medicine, or in particular in AI in healthcare or machine learning in medicine, that masquerade as predictions are not really predictions. Like you might hear things like, oh, we have the sepsis predictor. Well, there's no such thing as a sepsis predictor. Most of those things are figuring out the fact that the patient has sepsis and the care team doesn't know. It's a classification. And that semantics, pedantic as it sounds, is really important, because if you think you're predicting, you're tempted to do something to prevent that outcome. But if you know that all you're doing is classifying and diagnosing, then you think about treating and not prevention. So it does matter how we use these words, and it's a really important distinction to make. Sepsis things are classifiers and not predictors. The blue part, the recommendation, that's actually the hardest. Given the data have so many holes, quote unquote, biases, so to speak, it's really hard to do reliable recommendation. In fact, it's been a 40-year journey in medicine to figure that out. And I'm going to soon talk about one of the efforts that we succeeded in on our campus. So 3 things we can do. The other question to ask at this point is, are we doing those technical exercises, classification, prediction, recommendation, for advancing the science of medicine, the practice of medicine, or the delivery of medical care? And I'll give you an example to illustrate. It's possible to do some elegant math and figure out that this condition called heart failure with preserved ejection fraction has 3 subtypes. And that would be in the top row, first column. It's a classification advancing our scientific understanding of the disease, that this thing we thought was 1 is indeed 3. And subtype 1, you might die in 2 years, and subtype 3, you're fine for a decade. The second column, practice, would advance if we have 2 more things. I have a test, could be a blood test, could be an algorithmic test, could be an AI test, could be an imaging test, doesn't matter. Patient walks in, I do the test, and it tells me, are they subtype 1, 2, or 3? And then I have a treatment at my disposal to treat the ones that are at higher risk more aggressively or differently. Because if we just treat and then, or if we just test and then treat everybody the exact same way, all we're doing is increasing the cost of care. That's the middle column. And then the third, the delivery advances. If we do this test and train regime, we do it for 5 years or 10 years for 1,000 people or 10,000 people, they live longer, or they cost less, have better quality of life. And so as we think about the uses of AI, the uses of machine learning, it's really important to sort of park it in this kind of a mental grid to get a sense of exactly what is it that we're doing. I'm going to give you this one example of the middle column, last row. So it's an effort we did on our campus. It goes by the name of the Green Button Project. And the idea was quite simple. It's really been around for 40, 50 years, that when we have a difficult case at the bedside, can we query all of our similar patients, those patient timeline objects that we had for millions of other patients, aggregate that, and provide a better decision than we would otherwise make. So we did that. We actually ran such a bedside consultation service where you could refer a case to us, and we would provide a written report with a recommendation. Now, why does this matter? So on the left are some numbers, just to give you an intuitive sense for how unreliable medical evidence is. So in this case, this work that I was not involved with, a couple of physicians tracked over a period of about a week the decisions they made, and then went back. And it's a survey, and they were asked, for the decisions you make, did you have any prior published data? And about 80% of the time, they did not. Now, that doesn't mean the data didn't exist. It means they were not aware of it and did not have any access to it. And in their own subjective assessment, less than 3% of the decisions had a study specific to the question at hand that the physician knew. Now, you could argue that some of it is just better literature searching, but when you have about 80% of the decisions not have any prior published data, the thing to do is to analyze data on demand, which is what our prior project did. And when that project was done, our dean and CEO said, like, how are we going to scale this and share it to the rest of the world? So in a classic Silicon Valley fashion, we spun out a company that's this thing called Atropos Health. But the thing I want to share here is, yes, now we can do these bedside studies. On our campus, we used to take us about a day or two. The company reduced it to under 24 hours. sometimes even a few hours. And then with the advent of generative AI, you can now have a facility to essentially chat with the statistical study generation system, so you can have this study done for you on demand in a few minutes. And so it sort of gives you a sense for, we can go from data to better decisions with the use of different kinds of technologies, machine learning, chatbots, and so on, at a very rapid clip. All right, let's look at one more example. Middle row, last column. In this case, we're doing relatively simple AI. We're not doing deep neural networks or anything. We are predicting who's going to become medically costly next year. And then based on that, we would take a medical action, as in enroll them in a concierge care program or a diabetes management program or a blood pressure management program or something of that nature. This is a little bit old now. It was in 2015. And in our best estimate, by taking such proactive action, we estimated that about 10 to 15% of the future cost of care of those patients could be saved without sacrificing quality. In fact, doing less invasive procedures to them. So that's an advancement in the delivery that is driven by a prediction. So to sort of bring it together, AI, and I put it in quotes because it could be machine learning, it could be a model, that gives us some risk estimation. Something like, this person is going to be expensive next year. That's the first bullet point. You're predicting cost boom. But we can have a whole bunch of other predictions. And the ones on the screen, the top one are the operational ones. The top one are the biology ones. I put the cost boom one there by accident. The middle one are practice. And then the last set are, again, about delivery. So, for example, we can predict no-shows for providing patient transport. Or we can have image classifiers tell us whether a stroke is ischemic or hemorrhagic, and decide who to put on an air ambulance so that we can drill a hole and get the blood out from the skull. Across all of this, the consistent theme is that the AI just gives us a risk estimate. Value comes from taking action. In the case of cost blooms, taking the early intervention. In the case of this other one, mortality prediction, by performing advanced care planning. Or in the case of predicting no-shows, providing transportation support, or whatever else the actual intervention necessary might be. So that is what clued us into this interplay that we study and we teach on our campus, is that the model stratifies by risk. Value comes from taking some responsive action. So this little three-star logo is a quick way to remember it. The yellow thing is the computer science, the statistics. The green box is, given that number from the model, what are we going to do? Do we have the work capacity to follow through? Is the action, that's the red box, that we're going to take, is it going to have net benefit, all things considered? So we study this interplay. There's about 5-6 faculty that work on this, about 25-ish or so papers. And at the end of the day, after all of that, we came up with this sort of one key insight that's on the next slide, which is that we need to focus on what can we achieve given work capacity. So in this funny looking plot, what we've done is, on the x-axis, we've rank ordered cases based on 1 minus the probability of something happening. So 0 means highest chance of some event happening, whatever that event might be, cost bloom, being a hemorrhagic stroke or a mortality or whatever. And it's ordered from high to low. On the y-axis is we're tracking the cumulative benefit that we're getting. We take action on the first case, we get some benefit. The second case, we get more, so it keeps going up. We hit some maximum, that blue dot, and then we start seeing diminishing returns. The key thing is, how far down the list will we be able to go? And we have to answer that up front, because value comes from being able to act on the AI's output. And so after we've done all of this work, we sort of encapsulated all that. I want to go one more slide. Here. In this approach we call FIRM. fair, useful, reliable models. And it's a multi-step process, but the essence of it is that one plot that I was showing you. What can we achieve given capacity? And so in the first step, we ask a whole bunch of questions. We do usefulness simulations. We do financial projections. We do ethical considerations analysis. Then we ask the question, how to build a model, the yellow box. And then stage 3 is an honest assessment. Did we change what we wanted to change? So we got to monitor, we got to do some prospective evaluation. So this is sort of 5-7 years of work packaged into a process that we actually use on our campus on a routine basis in our own healthcare system. But before we arrived at that, when we looked around, and the reason we are now sharing this broadly is that the way things are done right now is unsustainable. And I have some two shock and awe numbers just to hit home the point. So on the left is when we analyzed that if we look at all the guidance about how thou shalt do good AI, we looked at about 16 or 17 different sort of recommendations. Collectively, those efforts had 220 atomic pieces of guidance about how you should do good AI. And half of them was about how to build a model. Meaning, if we go back here, about half of the guidance in the community was about this yellow box at the top. And precious little on how should we do the workflow analysis, how should we look at whether it's ethical, how should we look at sustainability, and so on. On the right is an estimate that one of my colleagues calculated, doing some very amazing science, 4 sites over 10 years, validating a model that when you walk into the ED, tells you immediately who should get a 12-lead EKG versus who can wait for a couple of minutes for their registration to be done. It took them 10 years and about $28 million to get this tested, validated at multiple sites. And so this current organization of work, the way sort of medical research is practiced, is just simply unsustainable, which is another reason that we need these processes like that form assessment so that we can do these activities better in healthcare. So that basically brings me to sort of this little table. How do we do this responsibly? Sustainably could be another word you could put there. We like to think of things in sort of 3 steps. The first is discovery, or solving for the science. The second is development, or validating that the intent of what you're trying to do is going to pan out. And then the third is dissemination, or scaling. And the 3 stages are outlined in this little blog post, for which the link is at the bottom of the slide, around welcoming innovation. But for standard AI, like we've actually, at least we have a decent worldview. We know what to do here. The discovery is too slow, too costly. We know that, so we can attack it. The development, we know we need to focus on achievable benefit. That plot I was showing you, how far down the list are we going to get? And we know that we need to calculate financial sustainability, and for that, we might need to change business models. So for example, if you're classifying hemorrhagic or ischemic stroke, you only have 1 air ambulance, like that's not going to work, because what if 3 people need that particular facility? So that's what feeds into our firm assessment. The link is right there, furm.stanford.edu. And then I'll walk you through the firm assessment, and then I'll just acknowledge that the second column, generative AI, has a whole bunch of question marks, and we'll come back to that. All right, so what do we do in the firm assessment? Well, the first thing is the workflow. Like, what are we going to do? So what I have on here is an example workflow of a classifier that identifies a person who might have undiagnosed peripheral artery disease. And then a whole bunch of things happen. A vascular medicine specialist looks at it. We might need to refer them to a primary care doctor, who then refers them to a vascular specialist who does a ankle brachial index test. And the patient may decline it, they may agree, and so on. The point here is not the exact steps in this workflow. The point is that we need clarity on the responsible action right when we build the classifier. That's the key point. When we build that model, that yellow box, this is the green box, the policy and the workflow. What are we going to do when, who does it, and what is our threshold for action? So we do this upfront. This is directly from that form paper, so that you can look at it later as well. Now, in that same assessment, in that what and why, the first step, we also do an ethics assessment. We look at the different considerations about, the workflow that is going to execute. Is it equitable? Is the model reliable? Is there a governance process to decide if somebody disagrees with the output or what's being done? Is there autonomy in decision making, or are people forced to go along with what the model recommends? I'm sure some of you have seen the coverage in Stat News about algorithms used by insurance companies to deny care, and we don't want to fall into that kind of trap either. Again, better than done upfront in the first stage before anything is deployed. And so this form assessment process helps us do that. And then the little table is, again, from the paper itself. It is about how we use these assessments. So there's about 6 cases. The one we were looking at is the first row. And in the end, the summary boils down to how many people, how many patients are impacted. So it's about 1,400 in that example we've been looking at. Is it sustainable? And are there any ethical problems? If a large number of people are going to benefit, there's no ethics problems as far as we can see, and it's sustainable, those are the projects we want to advance further. So it's like a upfront analysis of so that we can find good projects to pursue. We also have to do some capacity planning. When you want to do responsible AI in a healthcare system, we can't just keep launching project after project after project. There's only a few people in IT. And so we did some basic operational engineering work and said, okay, if we want to do, if it takes us about 6 weeks or 8 weeks to do this assessment for ethics, financial projections, workflow simulation, and so on, how many concurrent assessments do we need to be running so that we can get through at least one per month? And so it's something called Little's Law, very simple, basic operations engineering 101 level thing. But it basically tells us we need a team that can handle 2 at the same time so that one is coming off the conveyor belt every month, so to speak. And all of this doesn't really get us anywhere unless there's good governance. So that's this life cycle of how we make sure everything we say we need done does get done. So that form assessment is that yellow box in the center with a black outline around it. And this is our workflow, but the gist here for a general audience is that on top is the operational work that your organization is already doing, like standard way of doing things. Right below that is your IT department supporting all of that standard work. Those everybody has. You need to add these 2 other things. The green row, which is governance. How are you going to make decisions, and whose job is it to say no? And then in order to make those decisions, what are the analyses, these form assessments that you're going to do to produce the numbers like patients affected, sustainability, the absence of any harm to certain subgroups, based on which your governance body is going to make decisions. So those are sort of the 4 key components. You have your standard work, you have your IT team, you need governance, and then this form assessment process to figure out, what's good, what's bad, what you should not do. So that's a summary of all of the work on our campus on making sure how we ensure that the things we do with machine learning are fair, useful, reliable, and all that. So all of this was nice and good till 2022, and then along came LLMs. And this whole thing kind of got a little bit turned around. And I showed you that little table where the last column was empty or had 2 question marks. So let's go through that. We have a couple of minutes. So remember this timeline. Now, when we say language, most of us will think of English, Spanish, German, Gujarati, Hindi, what have you, some natural language that humans use. But for a computer, a language, and that's why I put it in quotes, is a sequence of tokens that come from some finite vocabulary, like a dictionary. With that lens, the patient timeline is a language because these tokens come from a finite dictionary, ICD codes, CPT codes, LOINC codes, and things like that. So that EHR language, which is at the bottom, again, put in quotes because it's not a language you and I can speak, is a sequence of tokens that these two things happen at this visit. This prescription was done. Then the second visit happened at which something else happened. These are all codes that we see in the data. So if we take this worldview, now we have two ways of building language models. The top is the classical language, as in natural language. We have text, we have documents. We can learn a language model, and that would help us do chat and summarization. That's the general way of using it. But then we can use these timelines that we've been talking about for the past 20 minutes. And that would allow us to forecast what is going to happen. And that's a unique way of using language models or generative AI in healthcare. And so, again, I've been very sort of a proponent of verifying, do these things work as advertised? So for the general stuff, which is this blue thing, blue at the top, on our campus, we did a couple of projects trying to ask, do these things have benefit when used at the bedside? So I'm going to show you two examples, and we can do more in the Q&A. So on the left is we took some questions from that bedside service that we had talked about at the beginning of the talk, and it's about 60 or so questions, and we submitted them to GPT 3.5 and to GPT 4. And then the answers were shown to 12 doctors with the task to tell us whether the answers agreed with what we already knew, the reference answer, they disagreed, or they couldn't tell. And as you can see in the 3 rows of that table, from GPT 3.5 to 4, agreement goes up, disagreement goes down, cannot tell goes down. So that's great. But the bottom row is about 40 to 50% of the time, the 12 physicians couldn't decide what was the case. So it's like having a person at the bedside giving you confident sounding suggestions, and you can't tell whether they're right or wrong. Not high utility there. On the right is like the tasks doctors want done using language models. So here's an example. We had this project called MedAlign. And what we did was to ask how aligned are the language model outputs for medical needs. So hence MedAlign. So a task might be something like summarize from the EHR the strokes the patient had and their associated neurological deficits. And that has to be done in the context of a given patient's EHR. So we had about 15 clinicians type out the correct answer after reading the EHR. That's in the yellow box. And then we gave the same instruction and the medical record to a language model, and it fills out the green box. Well, it turns out even in the best case setup, 35% error rate in answering these kinds of medical prompts. Okay, so that's what happens when we're looking at these off-the-shelf, chat and summarization, regular language models. What about the other side, the red side? So I'll show you this one plot. Now we're trying to train models that forecast, okay? And so on the x-axis here, I have number of positive examples based on which I'm going to make my forecasting classifier or my predictor. On the y-axis is the performance, receiver operator curve in this particular case. We tried a whole bunch of things, the gradient boosted models, logistic regression, random forest, those with the orange, yellow, and blue, which somehow has gotten removed. And then there's the dark blue, which is the timeline trained language model. And as you can see, the blue line, the dark blue line, is always on top of the other lines. That's just higher accuracy, period. But the fun part is if you look at on the x-axis, the number where it says about 64, and then follow it up, you will find a blue dot at the AUROC of about 78 or something. But that blue dot is on par or better than the highest red, orange, or light blue dot, which means by using these methods, I can train a language model, or I can train a predictor that is as good or better than I could train with classical methods using all available training data. So not only do I get 3 to 19% higher accuracy, it trains 8 times faster and uses 95% less training data. And we've publicly released these kinds of models. We call them Climber and Motor if you Google around on GitHub or so on. All right, so that basically brings me back to sort of wrapping this up. And in the case of language models or Gen AI, I think we need to focus on this purple box, which is verifying benefits. Razor focus on that. There's lots of tech companies building models, cost millions of dollars, hundreds of millions of dollars, which academic sites cannot afford. But we are the ones who can ask these hard questions. Do these things actually do as advertised? That brings me to this closeout, which is for the generative AI, the last column, we need to develop this worldview. And so I've added a citation there, which wasn't there on the previous slide. And I don't know how the development and dissemination for this is going to scale. Is that ROI? Like, I don't know. I'm not yet convinced. And you see article after article coming out saying, maybe, maybe not. There's like 5 articles in the New York Times that say, is AI better than doctors or not, and giving conflicting answers. But the one thing I can say for sure is that we have to focus on verifying benefits. Like, that has to be there. All right, so that basically brings me to the end of this conversation in terms of how we think about building fair, useful, reliable models on our campus and the class, where we'll share that with you. And you got a little preview today.
Great. Thanks, Dr. Shah, for taking the time to share your knowledge with us today. First question here. How do you separate the data engineering versus data science work? Given how spread out and unruly healthcare data can be, I often feel like I only do data wrangling or database creation. Is that still useful overall?
Those two functions, data engineering and data science, have to live side by side. In fact, at our institution, we put it in the same team. We just call the team data science team, but it has more data engineers than data scientists. And you need to have this arrangement where they're not sort of on the other side of the fence, like throwing data at each other, so to speak. But they have to work collaboratively, because what the science that needs done will dictate the engineering, the extraction, the cleanup, and all that. And decisions will be made during the cleanup and extraction that affect the kind of science you can and cannot do. So those two things, like hand in glove, have to work together.
And then once you have your data usable, how long does it take from when you start analyzing or modeling the data to when you come up with something that's presentable?
So that depends on the team maturity. So the first time, it always takes way longer. And as you do multiple replications through that, it gets faster and cheaper and more reliable. So to give exact numbers, the first time we did something end to end, like we didn't have a team, everybody's volunteering their time, and we're sort of coordinating over email and Friday nights and so on. It took us 5 years to 7 years end to end. Okay, it's a really long time. The next time we did something, but we're building the platforms, the work procedures, and everything necessary to do what we did over 5-7 years and then redo it in a production setting. Let's say it took us 1.5 years. The third time we do something, we can do it in 4 months. And hopefully the next time we'll be down to a month. So that sort of gives you a way of, you can, as you do these replications, you can keep, reducing by 50%. And in 3 or 4 replications, you get to a stage where you're quite mature. Practice.
And then the next question is, how do you account for the accuracy of the EHR data?
EHR data, you have to take it as a given that they're noisy, they have errors and so on. Mm-hmm. So for anything you conclude, always look for multiple lines of corroboration. So for example, just because there's a code for diabetes, you can't believe it. You have to look at the HbA1c, you have to look at medications. For everything, you want at least 2 or 3 independent pieces of information confirming or corroborating that fact.
Is Stanford training its own LLM on medical analysis?
Short answer, no. We did try, but the way and the pace at which this field is moving, I think it's more efficient to take an open source model with no copyright issues, and then continue its fine training as opposed to train from scratch. Training from scratch is expensive.
Right. Another question coming in here is, what are the most promising applications of machine learning in medicine, and how can they improve patient outcomes and healthcare efficiency? And do you think that's possible to develop? It says develop it in low countries. Sure.
Low resource
countries.
So I think you definitely have to look at the structural issues of the healthcare system in which the work is being done. So I like breaking things up into either science, practice, delivery, or you could just say clinical and non-clinical to keep it simple and just have two buckets. Depending on the environment, you might prioritize differently. And I'll give an example. Here, at least in the US, in academic centers, we typically deal with complex clinical cases, and hence trying to throw a new technology at something that a human trained 10 years to do, probably not the wisest use of the technology. And so operational applications such as transcription, responding to messages, billing applications, so on, tend to have higher penetrance and adoption. But if you're in a resource setting where you have to do eye care management for a whole bunch of diabetics, and your choices are they get no eye care, or you can use a retinal scanning algorithm that might not be perfect as an ophthalmologist, but is 90% of the way there, you might choose to do differently and use AI for clinical care because your alternative there is no care. And so I think the choice you make and what's deemed important is definitely affected by the circumstances in which that technology is going to be deployed.
Is there an example where academic work was applied to solve real-life problems in the healthcare industry?
Oh, many. So I'll cite just one. If you search for Stanford Health Care, HIMSS Davies, DAVIES, you'll find more details on our work on predicting mortality for improving advanced care planning. And over the years this thing has been around, it's improved the care of over 6,000 patients, and that's what we got the award for.
Mm-hmm. These are great questions. So keep submitting these questions in the Q&A because we still have some more time too for Dr. Shah. Is generative AI applicable in behavioral health aside from the clinical setting?
That's a tough one. I've personally not worked with using generative AI, particularly chatbots for mental health. I know there's a lot of effort going in that space, but on the flip side, there's also like ridiculous errors. Like there was this incident about Gemini telling a high schooler to go kill themselves while it was giving homework advice. Mm-hmm. So I see the potential, but I would say I haven't yet made up my mind if that is the best use of the technology today.
Right. How do you figure out patients' involvement in implementing the FEMR model?
So here we have something called a Patient Family Advisory Council. Mm-hmm. And so in training the model, it's done with de-identified data, and the patients are already consented for use of their de-identified data for research. But then once the model is trained and you're using it to say, I don't know, predict or classify peripheral artery disease or what have you, that workflow that I was showing you is shown to a patient family advisory council. The actions we're going to take are also shared with them to make sure that if you put yourself in the patient's shoes, they would feel comfortable with an algorithm nudging care one way or the other. Mm-hmm. You're absolutely right that a lot of times it's the developers of the algorithms making those judgments or pronouncements, and I don't think that is appropriate. It is necessary to have multiple stakeholders, at the minimum, the clinician users, the patients, and the administrators, apart from the developers of the algorithm.
What are the practical examples of using machine learning in laboratories, like in histology, cytology, or flow cytometry? Mm-hmm.
So our pathology department has some quite interesting work. In fact, a faculty member, James Zhao, has a effort to like have a deep neural net that can sort of become your extension. And I think the effort's called nuclei.io. It just like you have your own spell checker and something that helps you improve your documents, it helps you read your slides. And it'll find the portions of the slide that a human should see. And then it also learns from your behavior. So it kind of becomes an AI that you have trained to behave like you and augment your work. So there's lots of stuff like that happening. I would say the cell sorter, which gives you a CBC based on shining some laser and doing some calculation, is probably amongst the most widely used AI in every healthcare system. Nobody counts white blood cells by looking through a microscope and using a cell counter anymore. So there's a pretty broad range in pathology. On the one hand, you could say these cell sorters, which have been around for several decades now, is the most prevalent AI in pathology. And the other end is this fancy things that help you read your slide and then stuff in between for sure.
What do you see as the most critical data gaps in current EHR systems, and how is Stanford Medicine addressing them?
I would say the biggest gaps are that we have, it's different to call it a gap. The biggest issues are that we have too many systems. A typical hospital runs anywhere from 500 to 1,000 IT systems. And Epic is one of them, or Cerner, or whatever your EHR system is. And then you'll have a PAC system, and have a lab system, and an ophthalmology system, and a surgery video system, and an anesthesia system, and so on. So I think it is a myth to believe that all medical data is in the EHR. In fact, it is scattered over hundreds of IT systems. And I think that is sort of the biggest gap, or you could say the biggest opportunity to combine it and put it in one place.
How do you advocate for removing bias in predictions made by these models?
So I have a pretty non-traditional view on it. So whenever the word bias gets mentioned, I think of two things. One interpretation of that is that there is a systematic difference in the model's performance for people belonging to different subgroups. And I didn't use the word bias. It's a systematic difference in the model's performance. And then another interpretation of the word bias is that there's a systematic difference in the accrual of some benefit, the action or its reward that we're going to do as a result of the model's output. And we don't want systematic difference for people belonging to different subgroups. And so the kind of bias to worry about is the latter. We want to make sure that the model plus the workflow, when they're used together, there is no systematic difference in the accrual of benefit to people belonging to different subgroups. And so that is dependent less on the model and more on our policies and the workflows that are driven by the model output. And so I would encourage focusing on those as opposed to just removing the model side differences. In fact, we have a blog post many years ago now at the Human-Centered AI Institute about when algorithmic fixes fail. So if you search for that, you'll basically find this breakdown and some suggestions on if it doesn't work that you can beat out the difference from the model, what else can you do to make sure that the accrual of benefit doesn't remain systematically different?
Are traceability, explainability requirements slowing down progress of AI model advancements?
So short answer, yes. But the right answer is kind of it depends. So I'll cite another blog post, which is about should models be explainable? And on that, if you Google for that, it's one of our HAI blog posts. It breaks down this notion or need for explainability, interpretability, or transparency. Those three kind of words get used semi-interchangeably into its purpose. So sometimes you want that in order to debug your system, and we call that the engineer's interpretability. Sometimes you want to know so that you can get an idea of what you can do to mitigate that outcome. So that you need causal interpretability. And sometimes what you need is you just want to see that so that you can decide whether you can trust it or not. And so the needs of these three different scenarios are quite different. So if you imagine them as three circles and make a Venn diagram, you get 7 zones. So you need to know what is the purpose somebody's asking for explainability or interpretability. And then if the purpose is to establish trust and you keep providing the engineering explanation, in fact, it might set you back. And what you might need to do is literally do a prospective study to establish trust in a randomized setting. Like most physicians, my physician friends, can't explain to me how Tylenol works, but we trust it because it's been tested so many times. Same thing for a lot of drugs. I mean, there's 4,900 or so drugs, and for a lot of them, we don't know how they work. But we've tested them prospectively to establish the trust that they do work.
Mm-hmm. Are there any studies to compare error rates in medical diagnosis and treatment with assistance from AI models versus when it is only based on human effort without AI?
Yes, there's a couple of efforts already. Now, like the most recent one I know of is a colleague of mine, Jonathan Chen, where they gave a few case vignettes to physicians, gave the exact same case vignettes to GPT-4, and then gave doctors those case vignettes and access to GPT-4 and say, hey, use AI to help yourself. And the finding was not what everybody expected. Turns out that when doctors are given access to AI, they sometimes shoot themselves in the foot and make mistakes. So just AI was better than doctor plus AI. You can conclude all sorts of fun things, but in Jonathan's own telling, part of the reason seems to be that the physicians that were given those vignettes and the AI didn't really know how to use the AI. So they were using it in a very suboptimal setting. They were using it more like a search engine, so to speak. And so I think more work needs to be done so that we know how these things can be used in practice, as opposed to just ask the question, should they be used or not?
The next question is, full EHRs can be considered the raw material to teach AI. Do you agree?
Not entirely, because you do want the stuff from the textbooks and sort of a sanitized version of online sources like UpToDate or what PubMed or what have you. I wouldn't make EHRs the only thing to train an AI model or teach an AI model. But yes, it is one of the raw materials.
It says, other than GE PACS AI, are there any practical medical imaging AI in work?
Tons. I mean, I'm not personally working on medical imaging models, but if you look at the FDA's SAMD approvals, about 992, there are roughly 1,000 things approved, but half or more of them are image-based. 2/3 of them radiology, the other cardiology.
Okay. I think that's our last question. If there's any more questions, go ahead and put them in the Q&A box. If not, we can move on. But I think that was our last one. All right. So in that case, we can wrap up. So thank you for sharing your questions with us. And again, if you want to learn more from Dr. Shah, feel free to join our Applications of Machine Learning and Medicine program. You can also explore more from the Stanford Center for Health Education by visiting healtheducation.stanford.edu. We'll also be sending out a recording of this session via email very soon, so feel free to revisit this content. And again, thank you for joining us today. We hope you have a great week. We hope to see you again at our next session. So thank you.
Thank you. Thanks for having me.
Thanks, Dr. Shah. This is great.